Start off. Yeah, excuse me. All right, well, so 1 second here. My name is a little spelled here. Hi, good morning, everyone. I'm Saurabh Mukewar from Midas Hospital. This is a Sunday morning. Thanks for logging in. Today, this is our part 2 of the Eus for Beginners event. Yesterday was wonderful, and we had a lot of participants and a wonderful discussion as well. So today we'll be discussing endosonography guided tissue sampling. We have with us Dr. Vinay Dheer, who's a renowned, world-renowned expert in endosonography guided procedures. And thank you, Dr. Dheer, for sparing a Sunday morning for us. And we have the Olympus and Boston team who has been instrumental in organizing this event for us. So thank you all. And I will hand over the proceedings to Dr. Dheer to start off with basic talk on EUS FNB, followed by some cases that we did. We figured that it's probably better that we just get a live case recorded and show it at a reasonable hour. And that's why a case has been recorded, and we'll be discussing, I'll be narrating how the procedure was done, followed by Olympus team discussing the cleaning and disinfection, and then some discussion, and we'll wrap up by 12:30. Okay, so I'll hand over the proceedings to Dr. Vinay Dheer, and he'll be giving a talk. So thank you, Dr. Dheer.
Thanks, Saurabh. Thanks for involving me in this conference workshop. It's a pleasure to be here with you all on a Sunday morning. It's nice and cloudy here, beautiful. I hope you have the same weather there. So my talk is on EUS guided FNA and FNB, the basics. I don't talk much on this. Most of my talks are either on basic technique or on interventions, but let me try to give my views on this whole topic. So 1992, Peter Willman devised the first FNA needle. And at that time, we all did not realize, but now we realize what a momentous occasion that was, because for the first time, gastroenterologists could go outside the lumen of the GI tract. They could venture into the periesophageal, perigastric, periduodenal, perirectal areas, subhilar areas. So a whole new gamut of possibilities came alive with that one single development. Initially, the needles were fine needle aspiration needles, and they continued to evolve with various companies bringing out different needles. This is, I think one of the most researched subjects, as I will show you, the needle, EUS, FNA, and FNB, the number of randomized trials that have come about in this topic is mind-boggling. And we will discuss all those briefly. So the basic is you find a good indication, you learn how to position your scope, as Saurabh will show in his cases, and then you puncture. So it doesn't look like absolutely some rocket science. Looks very, very simple, but there are issues. So what are the indications for diagnostic EUS FNA and FNB? You have subepithelial lesions, large ones, small ones you don't need to, large ones you should. Thick gastric wall, important because endoscopic biopsies are often negative. Lesions in the pancreas, solid or cystic. Left adrenal, liver lesions, liver biopsy is becoming fairly common now with EUS. And lymph node sampling for GI cancer, if you are into oncology, whether you want to sample lymph nodes of various cancers, and of course, non-cancerous mediastinal and abdominal lymph nodes, tuberculosis, sarcoidosis, both are very common in this part of the world. So we get lots of cases for mediastinal and abdominal lymph nodes. So these are the common indications, and Today, the practice has changed so much that almost 70 to 75% of my work is only doing biopsies, FNAs and biopsies. So we have evolved from a simple tumor staging tool in 90s to now mainly giving tissue diagnosis. We are not asked to do tumor staging much because CTMR have become much better. So we are asked to do a tissue diagnosis in various scenarios, and that remains one of the most important areas for EUS. So how do you make EUS FNA outcome better? There are multiple issues in it, and this is a bit historical. I will show you what progress has happened. So you need, of course, a good endoscopist who knows how to do FNA. A good pathologist, very, very important, especially if you are doing an FNA, a pathologist with experience in cytology is crucial. Which needle to choose, which aspiration technique to go by, how to handle the tissue once the tissue has come out, how to process it, how to send it to the lab. And then, of course, where is the lesion? What is the location? What type of lesion it is? Solid, cystic, mixed. So those things determine the outcome. Now, this is a long list, in my opinion, and we have arrived at this, but an ideal solution would be to cut down a lot of these things. So, for example, needle selection and aspiration technique should go. There are too many things about this. We should make it simple. Tissue handling and processing should go. We should make it simple, just like we do for our endoscopic biopsies. So these complexities need to go. Pathologist experience, if we are taking biopsies, probably the experience in cytology may not be needed. So simplifying the procedure for us as well as for the pathologist is what is necessary. I think in the last 2 decades, we have experimented with a lot of things, lot of techniques, lot of rows, modes, this, that. And I think finally, in the last 3, 4 years, we are arriving at a situation where things are becoming simple for us. So a variety of aspiration techniques are there. Fanning, fanning is basically one is you puncture. So you have two things. One is a pass and one is fanning. So a pass is when you go from the lumen into the lesion. A second pass will be when you come back into the lumen and go again into the lesion. So that is a pass. Fanning is once you are into the lesion, you change the direction of your needle without coming back into the lumen. So you come to the periphery of the lesion and then again going in a different direction. That is fanning. Now, where to fan, centrally or peripherally, these questions have been asked. How fast your needle should go in and out, it has been studied extensively, and various techniques have been devised on this. There is a door knocking technique where you advance the needle very quickly. You're knocking at a door and allowing the handle to hit the stopper. Of course, I never use the stopper. And then you have a woodpecker technique where needle is moving very finely and rapidly. So this is a woodpecker technique. How many to and fro movements you should make, how many passes you should do, should you use the stillet or no, and you have randomized trials on each of these. So suction, whether to apply suction, whether not to apply suction, wet suction, where you put a little bit of saline in a tube and then apply suction, slow pull technique. So it's a plethora of technique choices for a beginner, and it appears very, very confusing. We will simplify it. Then once you have taken out the tissue, what do you do? Do you have a pathologist on site in your endoscopy room who is looking at the slides? Do you have the capability for rapid on-site evaluation? you learn macroscopic on-site evaluation. That is, you look at the material that has come out and look for whitish core-like materials. Then smear on the slide, cell block. So lots of things in pathology, sending the specimen, processing, complex things once again. And then, of course, which needle to use in which area, 19 gauge, 22 gauge, 25 gauge. So choices, choices, and choices once you are doing an EUS. So one thing is very clear, and this is Shyam's fantastic trial, which showed that fanning helps. So if it is possible, in some areas, some locations, rarely fanning may not be possible, but if possible, please fan. What happens is, for example, if you have a lesion in the head of the pancreas and you go in a particular area and then you withdraw your needle. When you withdraw your needle, that needle has created a small empty space in that tumor, which immediately fills up with blood because it is a vascular lesion. So if you go again in the same direction, all you are going to get is blood. So you should not go in the same direction again. You try to go in a different direction. That is called as fanning. So fanning should be done. No question about it. See the difference? So definite difference in outcomes. So please do fanning. Number of passes. When I was learning, we were taught 6, 7 passes. Please do. Why was number of passes important? Because we were not sure what we were drawing out with the FNA needles. Most of it would be some hemorrhagic things, and we were new and we were learning. As we became better, we realized that so many passes are not required. And I think worldwide the same phenomena happened. So probably if you're using a FNA needle, 3 to 4 passes is what is required. More than that, you should not do. See this, 3 passes gives you good information in majority of cases. Use of stillet or no stillet, lots of randomized studies, there is no difference. You want to use it, use it. You don't want to use it, don't use it. It doesn't affect the outcome at all. So stillet is a fine wire which goes through the center of the needle. Its primary use is to keep the gastric mucosa or the esophageal mucosa which gets sucked in, to keep it out. So, and also it provides stability to the needle. So whether to keep the stillet or not to keep the stillet, there is absolutely no difference between the two. Suction or no suction, again, lots of trials are there. So in suction, what you do is you use basically about 10 ml or 20 ml of suction, apply it to the tip of the control section of the needle, and then make your punctures. So it is expected that because there is a suction, more material will come in. But with that, more blood also comes in. So the idea is good, but it makes the smear hemorrhagic. So again, there is no clarity on this. Some people like suction, some people don't like suction. I never use suction. So unless it's a fibrotic mass, my first pass has not elicited anything else. And all these things apply mainly to the FNA. When we discuss FNB, I will tell you how all these things have disappeared. Wet suction is basically that negative suction, that syringe that you are used, fill it with saline and then apply suction. So there is one study by Rajiv, my friend, small number of cases. He says that it is better. So I don't know how many people use wet suction. I don't use it. Now, slow pull technique, there is limited data, but there is a widespread acceptance of slow pull technique. Most of the friends I know utilize slow pull technique. Basically, what you do is you withdraw the stillet slowly, or your assistant withdraws the stillet slowly. while you are making the punctures. It creates a very gentle negative pressure in the needle. And true, it causes less blood contamination and increases the yield. So we use this slow pull technique. So out of all this confusion, fanning is good, slow pull is good. Door knocking, woodpecker, I don't use. I'm giving you my personal preference. You use whatever you like. Suction, I don't use. Wet suction, I don't use. Slow pull is what I prefer. So fanning and slow pull is what I would advise. Once you have got a tissue, as we discussed, rapid on-site evaluation, macroscopic on-site evaluation, cell block. So Rose had a big impact in increasing, there is data on it, increasing the diagnostic accuracy and decrease the needle passes. That is for sure, because you have a pathologist sitting there who will tell you that this sample is okay. Don't go for the next pass. However, there was a problem because having a pathologist or a cytotechnician in room is not easy. Only the big institutions can afford it. The cost goes up. For us to arrange a cytotechnician is very difficult in private institutions, and then charges go up. So we have never used Rose, honestly. We went without Rose. We were more into the Mohs mode, where we looked at the sample and said, okay, we were using FNA. Even now, when I'm using FNB, I don't use Rose. We only use our naked eye inspection to see whether we have got a core or not. Of course, later on, good data, randomized data came out, which suggested that Rose probably does not affect the EUS FNA results, and I agree with this. We have never found the need to do Rose, and I think I'm using very strong words here because there are very, very big proponents of Rose, but I'm giving you my experience. We have never felt the need of Rose at our institution. So Mohs is, you can see here, nice white coats, beautiful. You don't need a Rose in these kind of samples. So if you have a core of more than 4 millimeters, you send it to the lab and they are very happy because they got a core. So Mohs is a more practical, but we do not have much data on Mohs. A lot of people use it. Cell block, when you are not sure what is happening, you do not see a white core, you send whatever solid material is there, fix it in 10% formalin for a histology examination. So that also is supposed to improve your outcomes. So all these obviously are pointing to imperfections in our needles or technique. That means we are not sure what we are bringing out after puncturing. So we need all these kind of things. Let's come to a very important topic, that is the needle. So as I told you, when we started, we had this variety of needles, 19, 22, 25 gauge needles. They were nice, but we needed to do more passes. And our pathologists were very upset because at times they'll get 20 slides to look at, which is not good for any pathologist's health. And then came Rose. If you saw on Mohs, there is good tissue, no Rose. So we used to get small amount of tissue, and it was a cytology, not pathology at that time. Then came the biopsy needles, and I think this has been the most important advance in our tissue acquisitions. So you have three generations. First generation, I don't know whether you remember, you had a true cut biopsy needle, which you could use only in large lesions. You could not use it in small lesions. It was a 19 gauge needle, cumbersome. It was quickly changed to a reverse bevel or a pro core from Cook. That was a good needle. But the third generation needles are what the major advance has taken place in this. So you have a fork tip, a Francine, and a forward bevel from Procore. So Shark Core, Acquire, and Procore. These three needles, I think, have changed the scenario completely. So whatever I have discussed before this becomes irrelevant. Oh, my slides are not moving. Why? Okay. So eliminated the role of rows. So now you see here, these are the FNA needles with different kind of things where you had a side port, you have a core trap, a variety of things. And then you have these new needles, the short core, beautiful needle, very, very nice needle. Even intracystic biopsy needles, the Mori forceps became available, which is pretty good. Um, Meta-analysis comparing FNA and FNB. In diagnostic accuracy, there is no difference overall, but the number of passes are significantly less with fine needle biopsy. So you can still use FNA needles. There is nothing against using it, but the number of passes become much less when you are using um, fine needle biopsy. There are 13 RCTs comparing fine needle aspiration and biopsy. Fine needle biopsy is supposed to offer better histology quality with fewer passes. So there is no logic in using FNA anymore. There is an issue of cost, yes, but I don't think there is such a significant difference in cost. So this is a very, very good study again from Shyam, retrospective, but very large number of patients. They compared FNA and FNB and they showed us that the only variable which was significantly having effect on the outcomes was whether you used FNB or FNA. Anything else was not significant. So you can see here in memoriam, a very provocative title by Shyam. So they said FNA is dead. Different FNB needles, there have been comparative evaluations. Um, Procore 22 and 25 are good, but forward bevel, the new one is superior to reverse bevel. Francine and fork tip are comparable as far as results go. Both are very, very good. Uh, this is another interesting issue, and I keep getting patients because we have a lot of oncology work and they want genetic workup from biopsy samples, and FNA is of no use in this. So if you want to do a genetic analysis, a patient who says, no, I want treatment only for myself, personalized treatment, you need to do this analysis. And you see here that you will find that enough material is generated and you can do next gen sequencing in that. So this is one study where you can see that FNB significantly higher histology core, total tissue area is high, diagnostic tissue area is high. So in such cases, no question, use fine needle biopsy. Some of the examples I will show you here. This is a patient who came to me after a negative biopsy outside. It's an ampullary lesion. They biopsied and the biopsy was negative. So the surgeon said, please do an EUS guided biopsy. So this is a EUS scope. We are going down into the duodenum. Oh, is it the same? No, no, sorry. This is a second case. This is a patient with thick gastric wall. Thick gastric wall, 3 times endoscopy is done, once in Jammu, twice in Bombay, all negative. So patient came to us, and you see here, this is linitis. There is no question about it. But because the surface does not show any tumor, endoscopic biopsies are coming negative. We also did an endoscopic biopsy first and did a frozen section. It came negative in 35 minutes. So we shifted to EUS. So you see this classic linitis plastica, no doubt about it. But you see here, grossly thickened gastric wall. It's almost 15 millimeters. All layers are thickened. Now here you see that individual layer pattern is still preserved, and that is why endoscopic biopsies are coming negative. Surface is looking okay. So you need to go here to get a biopsy. So Eus biopsy was done. We used 22 gauge acquire, and see here we went deep underneath the surface. So this is one wall, this is another wall, this is the lumen, and we are taking a biopsy from the depth of the thickened wall, and sure enough, it came as adenocarcinoma. So this is a very, very good utilization of core biopsy. We have done similar things in esophagus also. We have diagnosed tuberculosis where the surface is okay, but the wall is thick. We took a biopsy like this and it came tuberculosis. So this is a very good indication for EUS guided biopsy. So this is the second case I was talking to you about. So this is the EUS scope. You see bulging papilla. This area looks abnormal. You see, I could have taken a biopsy from here, but because outside biopsy was negative. Now see the EUS. There's a nice lesion here at the papilla. This is the bile duct coming here from above. So it's not a very big lesion. It's about, so we filled it with water. Important if you want to see the lesion properly. You see it's covered by mucosa all over except this one area. It's of entirely submucosal. It's more like compressing the bile duct. It's not coming from the bile duct. So we took a EUS guided biopsy. We went through the bile duct. It's okay to go through bile duct. This is just a 22 gauge needle. There is no problem. You see that I'm trying to fan in this small lesion by using my up-down control. And we took a good tissue. We got a good core. And the histology was neuroendocrine tumor. So this is the kind of cores we get with fine needle biopsy. This is from a single patient. You see you're getting an almost 17 millimeters of core material. So I don't think we need to think of the various things about how to process the tissue, how to send it. You just put it in formalin and send it, and straightforward, you will get a diagnosis. You will also get analysis of genetic analysis if you want. So things have changed. This is our own data. We have looked at the learning curves. So what we have looked at is visible core and histopathology. So you see the first pass, this is only the first pass. We were trying to see whether we are getting enough material in the first pass. So each pass sample we kept separately. And because we already have a huge experience with FNA, our initial itself was good in the first pass. But you see, as you approach about 80 cases, you are getting 90%. And if you approach 120 cases, you get 100% positivity in the first pass itself. So there is a learning curve, but once you have done about 100, 120 cases, single pass will give you 100% core, good core, and tissue histology. We also looked at the size of the core and at the blood contamination. So after about 60 cases, you see this, the blood contamination went down. See this? These are the grades of blood contamination. And at the same time, we started seeing an increase in the length of the core that we were getting. So we were getting initially 3 millimeters, then 4, 5, and after about 180 cases, almost all cores are beyond 8, and now we are getting cores more than 10 millimeters in all cases. So there is a learning involved. But once you've done enough number of cases, you get an excellent pathology material. Your pathologist is very happy. The patient does not come back. There is no doubt. So if you saw my first few slides, we were working on doubt. We were not sure what tissue was coming out. So a variety of techniques, a variety of things we tried. But now all those things are simplified. Just take a 22 gauge biopsy needle, puncture, And in the first pass, you get a good core, send it to the pathologist. So the whole process has become extremely simplified in the last 3 to 4 years, and I'm very happy about that. So my conclusions are fine needle biopsy has changed the paradigm. We are not using FNA at our place for last 2 years. I know, again, it may sound a little strong, but I'm giving you my experience. You can use FNA. There's nothing against using FNA, but I like to be very sure that my patient is not going to come back for a second attempt, which used to happen before. So number of passes have gone down, processing is out, pathologist's experience in cytology is out. A lot of these factors have gone out. A single pass core biopsy with a 22 gauge needle gives near 100% accuracy. Now, you can't be 100%. Sometimes you may need a second pass, but by and large, the message is after a certain number of cases, the procedure has become very, very simplified, and you can give diagnosis very fast and adequate diagnosis. Thank you very much.
Oh, hi, thank you. That was a fantastic talk. Nice to see your data. And I agree. I think with all these fantastic needles available, all that FNA DOUT data get just out of the window almost, isn't it? So thank you, Dr. Dheer. What I'll do is I'll present just videos of the cases being performed, and then we can go over questions and answers and have some discussion, if that's okay. Okay. So let me just start sharing my screen. Okay, hopefully that's fine. All right. So we have a case here. This is a 53-year-old female with a mass in the head of pancreas with obstructive jaundice. Patient underwent ERCP and a fully covered SEMS placement, and now was here for undergoing Eus FNB or FNA, whatever. So as Dr. Dheer pointed out, there are certain choices we have to make as we are approaching this case. The first is whether we need to do Eus FNB versus Eus FNA, and as Dr. Dheer has shown, I think FNB just clearly has superior outcomes versus FNA. The question then is, when would you even use FNA and when would I use it? I think personally, I feel the FNB needles are sharper, so they do give you a great tissue. But then if there are large vessels or so around, I sometimes have resorted to FNAs and smaller gauge needles in those patients. But by and large, otherwise, this is the workhorse is usually the FNB needle in today's day and age. The next question is, what size should we consider? We have various sizes, the 19 gauge, 22 gauge, and 25 gauge, which is available in most from companies. The 20 gauge by Cook is a different sort of size. In my personal preference, I like to use a 22 gauge as my workhorse for FNBs. 19 gauge FNBs, I like to use them for liver biopsies. I'll have Dr. Dheer's opinion on that a little later during the discussion. 25 gauge FNBs, I think these can be used in sort of the more difficult lesions, but the two needles that I go to are a 25 gauge FNA or a 22 gauge FNB. That's my personal take. Again, the techniques we've gone through, the slow pull technique, the wet suction or no suction technique. By and large, slow pull is what everybody seems to use. Or wet suction, but slow pull is the more popular one, and we'll show that to you. And then number of passes, again, as Dr. Dheer pointed out, we resort to macroscopic evaluation in most centers, I suppose, in India. And based on that, we determine the number of passes. And the other flip side is if there's any bleeding or so, then if we want to just be conservative, then we go for lesser passes. But generally, 1 or 2 passes can be sufficient in a lot of patients. And then whether the sample needs to be sent for cytology only or with histopathology is the other choice that you have to make. It's ideally both is what you would want to send it for. Any macroscopic larger cores can be put in formalin The rest can be smeared on slides for cytology. Now, if you look at the recent data with even the Eus FNB needle, there's a recent randomized controlled trial from gastroenterology. And if you see, there were about 5 or 10% patients in whom the cytology was negative, but histopathology clinched the diagnosis. So ideally, you want to send it in both, and that's the preferred way. So in our case, what I've used is the Boston Scientific 22 gauge needle, which is the acquired needle with a Francine tip. That's what I have used in this case. And what I'm going to do is I'm going to stop sharing and start the video so that you understand how the procedure and technique is done. Okay, so give me 1 second. I'm going to start the video. So we're going to demonstrate US-guided FNB of a pancreatic head mass. So this patient has a mass on the head of pancreas, has undergone metal stenting of the bile duct. So we are going to perform the EUS FNB today. So my scope is in the stomach, and what you see on the screen, now you see I'm advancing the scope towards gastric antrum, and I'm going to suction all the air out and then eventually intubate the pylorus, okay? So I'm suctioning the air, and then I intubated the pylorus. Now I'm in the duodenal bulb, okay? Now, what you immediately see is the head of pancreas structure, and I'll use my cursor to point it out. Now this, what you see on the screen, is the head of pancreas, okay? All right. So what you immediately see is a hyperechoic, well, I'd say a metal stent right there. I'm going to use the cursor to point it out. The metal stent is in the bile duct, and can use the flow to show this is the pancreatic duct, which also appears very prominent. There are a few vessels here. So we are going to characterize the mass in a second. So I'm going to use I'm in the apex of the duodenal bulb here. I'm going to use my big wheel towards me and actually also see a nice lymph node. And this is a portal lymph node here. Just show you on the screen right there. Okay. So as we start the FNB of the mass, now we need to get a good position. So I'm going to move the scope back and forth, use my suction to take all the air out, and do gentle clockwise, counterclockwise torque. Yeah, there you go. So now this is a reasonable position. My scope, I can see the mass right here. And I'm going to start with first using Doppler to make sure there are no major blood vessel along the way as we get the FNB. And also, what we need to do is to measure the size of this mass. So I'm going to freeze the image for a second. I'm going to use my cursor, not cursor, I'll use my calipers here, slightly starting from here, going all the way down. Then use another set of calipers and get the lateral dimensions. All right. So this is about 2.5 by 2.5, and this is corresponding to the size shown on the ultrasound. Okay. Picture, yeah. All right. So now what we'll do is let's go ahead and start with the FNB. I'm going to take out my cap. You can show that I'm going to remove the cap on the endoscope. And then using this needle right here, we advance it across. We have our technician, Shailesh, who's going to help me with this case. And here we go. Now, always make sure that your dials are unlocked, okay? So just show the dials that they're unlocked. So as I push this out, right, and I'm going to screw the FNB needle, all right? Now what I want you to see is what you can show is now, this is at 1, okay? So this is how much the needle is going to come out of the scope. So I like to keep it at 1, depending on the situation. And the next thing we do is basically pull the stylet out. I'm going to use the slow pull stylet technique today for demonstration. I'm going to pull the stylet out slightly, and then I'm going to unscrew the needle right here, right? And then I'm going to suction, and then I'm going to find my spot again. There we go. So I've suctioned out the air, and I'm now looking at the mass right in front of me. Right there is the mass. And all right. So then what I do like to do is gently push the needle out. So you see on the top right hand of the screen, the needle is coming out. Okay. So right there, the needle is coming out. I'm going to point it out for you. This is the needle, the bright echogenic needle. Okay. What I generally like to do is keep the dials in a neutral position. I don't like to use the elevator of the needle. Okay. And I'm going to use my suction to take all the air out. It's important as you do the FNA. And I'm going to torque the scope. I'll have my assistant hold the scope. Close. Okay. Yeah. I'm going to have my assistant hold the scope in a second. And then I'm going to gently, first again, we have to ensure there's no big blood vessel. And I'm confirming that there are a few vessels, but that should be okay. All right. All right, so I've torqued the scope. So I'm going to ask him to hold the scope for me. Can you show how he's holding the scope for me? So that the scope is in the torque position as I move my hand away from the scope. Okay, so my assistant is going to hold the scope in position, and then we can switch back to the view to me. Yeah, this one. Okay, and then I'm going to advance my needle gently right there. So now I got my position in place, but then we have lost the position. I'm going to torque again, and I'm going to push the scope in on the bulb so that it's sticking to the apex of the duodenum. In this case, I don't like to use the elevator. I'm going to use slight elevator, just a little bit. Okay, and then I'm going to advance the needle. What I like to do is I like to jab it because, yeah, there you go. Hold it tight, scope. Okay. And I'm going to push the needle out. All right, again. All right, so now we have the needle and I'm going to push the stellate out, although it's in the edge of the periphery of the lesion, but we'll reposition it. And I push the stellate out to clear the duodenal contents. Then I'm going to pull back gently. Okay. Well, no, yeah. Okay. In this case, I have to use the elevator. Okay, here we go. So I'm going to push it again and then pull back gently. I'm going to use the fanning technique. I'm going to push it again. Show it here, right there. And I'm going to pull back as. So what's important to demonstrate is that our technician is going to pull the stellate out as I'm pushing the needle in. All right, here we go. So I'm going to push it. And then he's going to pull it at the same time. So now here we go. I'm going to pull back the needle. What this does, it creates a slight negative suction, allowing the material to come inside. Okay. I'm going to do it again. So use my, yeah, there we go. It's a hard mass. I'm going to use my elevator again to pull it back a little bit. Okay, I'm going to pull back now. So now we're going to unscrew. Okay, good. Put this. Okay, so now you can zoom the camera on this. Okay. So the assistant is going to express the Okay. So I'm going to show you the next part of this case as well, and then we can go over the discussion part. Okay. So we are going to demonstrate the EUS-FNB of the lymph node in this case. Now what we are looking at is a portal lymph node. I'm going to do it across the gastric body. So first we are going to remove the cap, and then I'm going to advance the needle right here. Okay. All right. So the next step is so what I like to do is I like to keep this at 1 so that this needle is slightly out of the scope. Then I'm going to unlock the needle here. You want to lock it at a position, especially early on when you're starting out, so that you don't push the needle out beyond your intended course. So we are going to lock it at, say, 5 in this case, since the lymph node is right adjacent to the stomach wall. Okay. The next step is to pull the stellate out a little bit. We are going to, now here we go. This is the stellate. It's been pulled out. Let's demonstrate this, please. Yeah. Okay. And then I'm going to basically suction the air out of the stomach. Okay. And then we'll find the lymph node which we are going to target. So what you see on the screen is the lymph node. And I'm going to use my cursor to point it. This right here is the lymph node. Okay. And next, you'll see the needle coming out on the right of the screen. So I'll draw. Okay, there we go. So this is the needle coming out on the right side of the screen. You see this? I'm going to use the cursor to point out. This is it. This is the gastric wall. This is the lymph node, and this is liver. So I'm going to remove the cursor now. Okay. And then we are going to use flow to make sure there's no blood vessel along the way. And there's no real major blood vessel here. And we try to find an avascular path. Okay. All right. So next, what I'm going to do is basically what you have to do is really jab the needle inside the lymph node, because the lymph nodes have a tendency to just get pushed away. So I'm going to have my assistant hold the scope nicely here so that it doesn't move. Okay, that's it. So this is it. The scope has to be exactly in this position, so we don't allow it to move. And then I'm going to jab the needle in the lymph node. Okay. Right. So now show on the screen. Yeah. So that with the respiration, okay, there we go. So my needle is in the lymph node at the far edge of the lymph node. Yeah. Okay. So next, what we are going to do is I'm going to push the stellate out to remove the gastric contents in the needle. All right. There we go. So the stellate is pushed in. I'm going to pull out slightly. And what we need to do is to have my assistant slowly pull as I push the needle in. Okay. So now I'm going to first pull the needle back. Now you need to make sure that the needle tip is all visible at this all the time. So I'm going to move the scope back and forth, torque it. All right. So my needle tip is visible. I'm going to pull it back to the proximal part. Okay. And then I'm going to push it out again. Ready? 1, 2, there. Then I pull it back again. Yeah, there you go. And then I pull it back. Now I'm going to use a fanning technique, which means I'm going to move the needle in different parts of the lymph node. So I'm going to unlock my dial a little bit here. And then I'm going to move it with a different trajectory right there. And then jab it again. And then I'm going to pull back. Okay, let's look at the tip. Yeah, there we go. Okay. And then I'm going to move my big wheel a little away to get a different trajectory and jab it again. All right. So we overshot that time. That's okay. And then I'm going to pull back again. I'm going to big wheel towards me to get another different trajectory and then push it again. Okay. So then I get pull back again and then I get another trajectory, push it again. So you see that gives you sample of different parts of the lymph node as you pull it and push it out in different trajectories. This is fanning, okay? So it's important that you get different areas of the lymph node, which gives you a better yield than just pushing it in one direction. So I'm going to again move my big wheel. All right, there we go. And if you can show how the stylet is being pulled at every time I'm pushing, okay? Can you please focus on the stylet here and how this is being pulled out every time I'm pushing the needle, okay? So I push the needle again. Actually, once you're in it, you can just be smooth in terms of your push and pull. All right. Okay. So now we get another side here, right there. I'm going to use my big wheel again. All right. There we go. So yeah. So now we've pretty much sampled all the aspects of the lymph node. I like to go back and forth quickly. All right. Now, so we'll now unscrew and pull out and see what the yield is. Okay. Excuse me. Okay. Sorry. Excuse me. All right. So thank you. So those were a couple of videos just to illustrate how an Eus FNB is performed. I will let I think Mr. Santosh Babu talk about the cleaning and disinfection services, and then we can take some questions and answers after that. Okay. Thank you.
Hi, everybody. Am I audible?
Yes, sir. The screen is visible and you're audible, sir. Yeah.
Right. I'm Santosh, represent Olympus, work for the project management team and do a bit of training activities on reprocessing of endoscopes. Okay. So 10 minutes was a bit short time to talk on reprocessing of presentation, trying to talk about the basics, concepts of how you reprocess your endoscope. Before that, design of the Eus scope, yes, is much different in terms of compared to the regular scope. Different types of transducers available. It could be a radial scope, linear scope, mechanical scopes. These scopes are nowhere to be seen except in the form of mini probes. All these basically are reusable and reprocessable, disinfectable, and sterile. You can also sterilize them. We'll see one by one. Major aspects of an ultrasound scope could be the transducer and the distal end of the scope. For the scope, for the mucosal viewing, is all about the same sort of components like the objective lens, light guide, the LG cover glass lens, the nozzle, the channel. All these things are available. There's something unique in these scopes, the ultrasound scopes, where you have the balloon outlets, basically the channels for pushing in water and taking out. So this is the ridge or the gap that you see is basically here is basically the channel outlets for small little outlets for the water to come in and eventually the water to get sucked inside the channel. Fine. So predominantly when you're handling the distal end of the endoscope, I request you to be all gentle with the transducer, because at the time of handling or inserting a balloon, or especially while removing a balloon, if your technician isn't trained properly, you end up pulling out the acoustic lens as well. So please be careful in handling the distal part of the endoscope. Now going on to the channels of the endoscope, it's just like your regular scope channels. Definitely it has a suction channel, which also works as a instrument channel. Then you have the air water channel, air channel feeding in air or CO2 for inflating or probably to remove out the water content on the objective lens. Then you have the water auxiliary channel. Yes, we do have these auxiliary channels in the regular endoscopes for cleaning the mucosa. We do have such a channel in the ultrasound endoscope, which in a forward-weighing ultrasound endoscope especially. The elevator channel, yes, is also available. You have the elevator channel for the linear scope to orient the instrument. Yes, these are the open type elevator channels, which are common in the ultrasound endoscopes. Now, something which are not common in the regular endoscopes is these two channels, which is the balloon suction channel and the balloon water channel. So when I was talking about the channels, you'll also have to know which channels are brushable. Yes, only the suction channel is brushable and the balloon suction channel is again brushable. So these are the two channels that you can brush. The others are, you rinse them off, you flush them off with the fluids that follow through. Valves are different. The regular valve is something like this. This is your regular suction valve, your regular air water valve. The extreme ends are for the ultrasound valves, both for suction as well as air water. So different channels, yes, it's important to know how your channels are, and so that makes life easier for you to access them and clean them post procedure. Yes, reprocessing can be, it has to be done so that you avoid cross-contamination, nosocomial infection, but also can bring down or increase the life of the endoscope. Now, cleaning, disinfection, sterilization, yes. Are these the same? No, all three are different. Cleaning for removing gross debris, disinfection to kill pathogenic microorganisms, sterilization, you totally kill all the microbial life. Why are we not able to decontaminate the instrument properly? We don't clean the channel or brush the channel. So inadequate cleaning. Water is contaminated. Inappropriate disinfection methods. I've seen people just using part of the insertion tube dipped in detergent or disinfectant solution, which is not right. So inappropriate disinfection methods. And design faults in the AER is also leads to inadequate decontamination. Coming down to what chemicals or what types of solutions you use for all these three. For cleaning, predominantly it's a low foam neutral pH detergent. Disinfection, yeah, GA is well accepted, gold standard down the line, but some countries have banned it, but GA is still a good component to disinfect flexible endoscopes, high level disinfection. Sterilization, again, ETO is one of the tried and tested. It takes longer time, but ETO is possible for sterilizing the endoscope. The others are basically the gas plasma, probably for thin diameter scopes like bronchoscopes. And earlier we used to even do long time immersion in GA, probably for 10 hours or 12 hours, and attain sterilization. It's still possible. Autoclave, yes, autoclave only for the ET accessories. Reusable ET accessories is still possible, but definitely not for the scopes. We don't have any scopes which are autoclave in nature. Cleaning is the most important step. So gross debris has to be removed. So 90% or 95% of the bioburden is taken care when you do a proper cleaning. So mantra is clean it, clean it, clean it. A lot of accessories are involved, brushes, adapters, tubes. Make sure that they are proper and then they are proper functional before you use them on your scopes. If it has a dent, it has no bristles, please don't use them. Damage the scope. One common thing, my suction is ineffective. Yes, suction cylinder, if you can see, is all shaved off. So please, probably most of the technicians are trained. They know how to handle the brushes. If it is not being done properly, your suction cylinder gets shaved off, and then over a period of time, and then the suction is ineffective. Similarly, when you're gentle, small steps while taking it and taking it out. Disinfection, yes, as I said, these are very corrosive in nature and very harmful to the human. So make sure room is well ventilated. That recommends those steps. Please follow them. Again, contact time is equally important. Stick on to the contact time, and probably at the end of the day, you flush it with alcohol and then dry the scope for storage. If you do not clean the scope properly with the detergent, there's something called protein fixation that is happening. And then this is purely because of improper cleaning. So your color of the scope gets, cosmetic changes keep happening. Improper disinfectants or detergent use, you goof up the scope. So yes, periodic maintenance and regular upkeep of the instrument is very much necessary, and daily maintenance is necessary. Daily maintenance, yes, scope eventually lasts longer. How do you make it possible? Leak test. So if you don't do leak test every procedure, which is a mandate, you can get into problems such as these. These are real life photos which have actually spoiled the scope. Eventually, after maybe 10 procedures, 20 procedures, when you actually find out a problem, you eventually open up the scope and find such things, which is too late to save the scope. So it's all about rebuilding the entire endoscope. This is too late a point to save the scope. So please do leak test. Leak test, yes. These that you need to attach these water resistant caps. Some comes with the cable come attached, so they have a different type of connecting. So then come into the wash area. Please do. The first thing that you do is start off with the leak test. So the entire scope is basically sealed, and then you have those spaces in between the components filled with air, and then that's how, in case there's any leak in the scope, it's visible. If it's in the biopsy channel, the bubbles come out. So something like that. So never ever connect or disconnect the leakage tester while in water. There are a few steps that you need to know. Yeah. So this is the actual step that goes from pre-cleaning eventually to leak test, manual cleaning, disinfection, rinsing, and storage. So connections, brushing. Even though you have a AER installed, please, brushing is very much crucial to brush the channels prior putting them into the washer. Be gentle on the distal end, especially on the transducer part. Yeah. So after cleaning, after brushing, you decide whether you put it on a AER or continue to do the process. Coming down to rinsing water has to be, you do it at the end of the disinfection cycle. For a task. Drying of the scope, yes, you could still use a medical layer, less than 4 bar usually is used, and you can dry the external surfaces of the channels. Yeah, using an automated. So there's a school of thought that AER is better than a manual. No, both are the same. Manual cleaning or doing it with AER. There is pros and cons of AER also. Pros could be human involvement is not there. So your reproductive can do n number of procedures with it. Just a machine, program it, then takes care of it. Labor involvement is less. So many things are the merits of the AER. Demerits could be you have to maintain it. If you've not maintained it, you've invested heavily on the washer and then you don't maintain it, then back to square one. Biofilms, they're huge issue. So you'll have to take care of these biofilms in the water line in the hospital. So we do install pre-filters like these so that before they get into the washer, you filter them and then eventually give a bit of clean water into the reprocessor. So reprocessing room, ideally, yeah, that is blue line talking about the movement of the patient, then red line talking about the dirty equipment movement. This is one way of building up your endoscopy. Reprocessing area, asequential, one end to the other, it moves on. So a dirty scope comes in, you do the manual cleaning, eventually the disinfection part here, and then the rinsing and the drying part. So ideal situation. Same thing can be on the automatic washers also, but you still need to have some place for manual cleaning and then the automatic washer. Couple of photos from couple of institutes here. Then yeah, finally endoscopes definitely are fragile. Process is as good as the operator. Keep training, retraining your staff, or make sure that the staff is trained to handle the endoscope. Cleaning is the most, there's so many steps, pre-cleaning, manual cleaning, all those steps. Yes, cleaning is the most important step. Even if you've not done a proper cleaning, even if you're sterilizing the scope, no point in it. So sterilization is preferable to disinfection when it is feasible. Probably you have time, you have probably once in a month, or you can slate specific timing and then do sterilization. ETO, all endoscopes are ETO compatible. Then please refer back to your manuals because they give a lot of information. Please go through them. Yeah, that's my talk, and our purpose is to make people's life healthier, safer, and more fulfilling. Thank you. That was from my side, Dr. Saurabh.
Okay, thank you, Dr. Mr. Babu. Thanks for the talk.
Thank you.
I think it's something that's probably ignored, and I think it's essential that all the gastroenterologists and endosonographers doing EUS must be well versed with the cleaning and disinfection techniques. Because ultimately, if you are well versed, that's only when you will make the staff do it. Otherwise, the staff will, it's hard to get the staff pushing for this. It's only when there's a bad infection that you realize that the importance of these measures. And anyway, so thank you for that, sir.
Thank you, sir.
I have some questions for Dr. Dheer, and we do have some panelists, Dr. Anumit, who's here. And if you have any questions, please feel free to start your video and ask questions. So, Dr. Dheer, if you're there, I was going to ask you something.
Yeah.
Hi. Hi. So I had a question now. What's your thought on kidney biopsies? Have you done the left kidney is very close to the gastric wall. My nephrologist was a little apprehensive at times to do a biopsy, and we entertained the possibility of doing it. I have not personally done it. Have you?
No, I have not done it, but it can be done. It's technically pretty easy, and I don't think it is going to cause more problem than the percutaneous renal biopsy that they do. It will be much easier. So if your nephrologist is happy you doing it, please do it. No problem.
Yeah.
Technically, it's not a challenge at all.
Right. Exactly. I think it's probably easier considering that.
Yes.
Wall. And so anyway, that's one. Especially now with the core biopsies that we are getting with transgastric liver biopsies, it is encouraging, and we can probably do it, I feel. Yeah.
Yes.
Now, the other question I had was, what's your preferred needle? I think we did discuss offline once, but for Eus guided liver biopsies, I know there's some emerging data comparing the different biopsy needles and different gauges. What's your preferred ones? 19 or 22 gauge, and then if you do use a FNB needle, FNB, which particular brand, make, or you're flexible?
So I never use 19 gauge except for interventions. It's cumbersome to move. I can't go into desired areas where I want to puncture. So when you're using a 19 gauge, the scope position and other things, it doesn't move very well. So I prefer a 22 gauge. I have been using it for my liver patients for past 1.5 years. I have done many liver biopsies, and my personal experience is, and my pathologist agrees with that, is that we get a good core and excellent number of portal triads. Studies aside, I am pretty firm in my belief that a 22 gauge is good enough. There is no need for a 19 gauge for a liver biopsy.
Yeah. Yeah. And any preference of Francine type or the reverse bevel, Charcot?
So Charcot is, I don't think, is it available in India?
I don't think it's available. I've used it a lot personally.
Yeah, I know.
It's not available, I think, as of-
Me too. In only conferences in US, I have used Charcot.
Yeah, it's good.
It's a very
good needle.
So currently it's Francine.
Yeah.
22 gauge.
Yeah. Actually, there's some study to actually support the Francine needle compared to other needles for the yield in liver biopsies. I think I just came across something recently. My personal, I just started using the 19 gauge. I started at 22, which is fine. But somehow, anyways, it's a transgastric pass, so it's not that big a problem maneuvering. But I had a really fantastic course with the 19 gauge biopsy needle. Of course, we are looking at possible risk of bleeding, but so far, touch wood hasn't happened. And I think with the gauge being slightly, the needle being sort of wider, the thickness of the sample is more than the 22 gauge. But I guess at the end of the day, if the diagnosis is...
I heard lots of my other friends also talking about it. And what I am interested in is the number of portal tracts that we get. So you have to get certain number of portal tracts to give your pathological opinion. And 19 gauge I use in the liver. I do antegrade procedures all the time. So I'm not worried about bleeding. But I'm not very happy with the position that I want. So there are certain lesions, for example, in the liver, which I want to target. I can't target with 19 gauge, even the maximum up, which makes the movement more difficult. So that's why I generally, except for areas where there is a big vessel in front of the lesion, where I use a 25 FNA, not FNB. Everything else in my department is 22 gauge.
Yeah. Okay. The question was, excuse me. And do you end up using the 25 gauge FNB at all? I know it's one of those in between.
No, not really, because the need for 25 is basically uncinate process, and our 22 reaches very well in uncinate process. So I don't use 20. FNA occasionally, yes. FNB, no.
Right. Okay. And there are some questions here. Dr. Aarti Wazirani is asking, any experience of pseudoaneurysm post-pancreatic had multiple passes? Not personally. Have you?
No, as far as bleedings are concerned, they are pseudoaneurysm formation, no. Cyst areas are more, you can have bleeding in them, and you can have pseudoaneurysm before you puncture them. So we have had bleeding in cysts following aspiration or following pseudocyst drainage due to pseudoaneurysm. But pseudoaneurysm formation because of a needle in a solid lesion, I am not, no.
Yeah. No, I agree with you on that, yes. There were questions about any tips for visualizing and biopsy of right adrenal gland?
Good.
Lymph nodes.
Good. Now you can visualize right adrenal in all cases. There is absolutely no problem. So you have to go one of the two ways, either image the segment 6 of the liver and go down. So basically what you have to do is look at the IVC in the duodenum, not the aorta, IVC. Look at the edge of the liver, the segment 6, and look at the right kidney. These are the 3 landmarks. And you will find your right adrenal in almost all cases. Little bit of turning and twisting. But if it is big, if there is a lesion, all the more you will find it much more easier. So it's not a difficult thing to pick up the right adrenal.
Okay. What step do you use to disinfection the needle to be reused like normal scope according to the machine?
This question should not be discussed in forums.
So the needle is not advised.
See, there are some things which should remain silent.
This is impractical not to discuss. But okay, now there's a question, particularly for the case Aarti Wazirani is asking, Any point of biopsying the lymph node as well in this particular case that I did?
Yeah.
My, excuse me. See, actually, this was a smaller lesion. I did it. I didn't get a beautiful core, which I would probably get in a larger needle sometimes, a larger pass. I said, all right, like the lymph node was more easily accessible, and it's part of the same pathology, and it won't change the management in terms of staging. It's still part of the operative field if and when the patient undergoes surgery. But just to sort of increase my yield, I've done it. You don't have to do it unless it's going to change your staging, in which case some would argue that just do the mass that will upstage the most.
Saurabh, I will disagree with you humbly here. That lymph node is very important to biopsy. It's a very large lymph node.
Yeah.
It looks malignant, no doubt. But if it is positive, maybe your surgeon would not want to operate and would probably give a neoadjuvant chemotherapy before going.
True.
So, okay, if there is something very close to it, which is 5 millimeters, 6 millimeters, which will come out with the specimen, fine. This is at the hilar region. So I would definitely biopsy it because staging is important. Your surgeon's decision might change. And it's a pretty big lymph node. It's not a small lymph node. So I would definitely biopsy this. So I agree with you on that. Please biopsy this.
Yeah. I think you're right. I think the question really, if you're determining neoadjuvant and surgery versus surgery, if that's sort of the thought, fair. That's a totally valid point. Agree. Okay. Periportal. Yeah, I think she is mentioned. Anyways, so I think we sort of alluded to that. There's a question on celiac plexus block, a little sort of out of the curriculum for today, but I am happy to answer it now that there were no other questions. So the question is, excuse me. Actually, before that, we can take this one. So if you have problems from D2, any tips? How do you go about a D2 FNA, FNB if you have problems? Dr. Dheer, any thought? I didn't sort of answer.
Sorry, I didn't hear it. Sorry, I was reading the question.
Okay. Scope is always very unstable in D2. Any tips for FNA in D2?
No, it is. Saurabh showed you very, very well how to stabilize it. So it is not always unstable. Only when you are probably biopsying from D1, D2, you ask your assistant, teach him to hold the scope in the same position that you give him. That stabilizes the scope. Some people use a balloon. I don't use a balloon. A, it is expensive. B, to me, it changes the trajectory a little bit. So I don't like to use a balloon. So what I use is exactly what Saurabh uses. I ask my assistant, if need be, to just hold the scope for me when I'm taking the biopsy.
Yeah. Okay. Oh, actually, I realized that there are a lot of questions here. So we lock the up and down knob before doing fanning with elevator. I agree. I would not use fanning with the elevator. Personally, I use the big wheel, like Dr. Dheer also pointed out. So you don't have to use the elevator to do the fanning technique. You just have to use your big wheel on the scope to move it with the scope back and forth to the fanning technique. Any tips for visualizing and biopsy of small submucosal lesions and anterior of the stomach or antrum, where keeping water in face is difficult? Yeah, but I think the question is, how small a lesion can you successfully do FNB, of? Because I think once you're looking at a 1 centimeter territory, I don't think your yield can be a big challenge. What do you think, Dr. Dheer?
The question is good because antrum is a challenging area for biopsy. It's full of air. You pour water and it goes off into the duodenum. And some areas. So it is a challenging area. There is no doubt. But if you need to biopsy it, you probably need to suck out all the air, put some water so that at least some reference you get, and keep changing your position till you get a good window to biopsy. So it comes to us and we also find it challenging, but it is possible in almost all cases. When there is no air, you put little water, it goes off, you put little more. It should be possible.
Yeah, agree. Okay, any tips and tricks for taking peritoneal biopsy and liver biopsy? We did discuss the liver biopsy just briefly right now. Is it safe to do it in a cirrhotic liver? It's a good question. The coagulation profile is what determines that, is what I would say. But then that's also hard to measure. So it is safe. I think it's done. I've done it before. Dr. Dheer, I think the portal pressure measurements that are being performed with a smaller 25 gauge needle across the West, I've done it successfully. But when you're talking about FNB in a cirrhotic liver, probably a 22 or 19 gauge, whatever you choose, problem is the uncertainty of the coagulation profile. If your child's A, probably okay. But I think if child's B or C, even if the INR is normal, you're not always certain that the coagulation profile is normal in these patients. So be careful, I would say. Dr. Dheer, any thoughts on that?
So it's reasonably safe, as you said. I have not faced much problems, provided, as you said, your coagulation profile is normal. And the simple rule that we follow everywhere else, avoid a major vessel. If you're doing it in the liver or wherever, in the peritoneum, don't go through a vessel, definitely in a cirrhotic, because then he will continue to bleed. If you have small vessels, it is okay. If you are using a 22 gauge needle, even if there is a bleeding, it will stop unless you have done multiple passes, you have gone in multiple directions and created a lot of damage. That should not happen. So be straightforward, smooth, go into the lesion, one pass, come out. So you have to have an indication. If there is an indication you're suspecting, for example, tuberculosis, and there is a nodule which you are seeing within the ascites, you should be able to take it. But I have also, because I keep getting reports from all over the country and outside the country, I am aware of patients who have bled to death. Not in my department, but I'm aware patient went home, came back in the evening in shock. So yes, the warning given by Saurabh is also valid. So when you are playing with these cases where the chances of bleeding are more, I would suggest make your procedure quick. Don't try too many passes. Go with a smaller needle, and as far as possible, one pass, maximum two pass. Don't go beyond that.
Yeah. And part two of the question was tips and tricks for taking peritoneal biopsy. I've never done it. I've never seen a peritoneal
I have
nodule.
done it in several cases, no problems. No problem. If you are seeing a lesion,
I can see it.
again, these are cases of tuberculosis most often in India. So you have sometimes peritoneal carcinomatosis where we don't biopsy because there are other lesions.
Right.
But if you see it, you can biopsy it. It is safe. There is no problem. I think there is some data published from Surinder Rana also on this. So it is safe. Go ahead and do it if you see a good enough lesion.
Right. And there's one more question. Sometimes we see gastrodunal artery coming between probe and pancreatic head. It happens when we push more towards the bulb. It becomes difficult to FNA how to avoid and tricks in such instances. Personally, I think yes, sometimes it is hard. Sometimes there is a vessel, no matter which direction you see it in, it seems to show, but you have to try your level best to find an avascular path. The other thing I think in terms of vasculature and doing FNAs, or for that matter, any therapeutic interventions, I think what sometimes people don't realize is when you press the scope very, against the duodenal or any gastric wall, you're going to compress a vessel. And then you see it with the Doppler and you won't find flow and you feel like it's an avascular path. So I think it's always a good practice that you pull the scope out slightly to ensure that there is absolutely no large vessel that you're compressing by pushing the scope in, trying to get a great view of the lesion. I think that's what I would advise personally. Dr. Dheer, any thoughts on the question? I know you answered.
Like,
Of course, avoid the GDA.
often
Don't want to touch
compress the vessels, and we
Sorry.
don't see and we feel happy. You're right. My advice stands the same. So don't bring out the needle back into the lumen. Once you are down in the same path, you try taking the biopsy if you have gone through a vessel.
Yeah.
Don't try to take it out, put it in another direction. Then it is real problem. GDA, it's an artery. It's not a small artery. Try to avoid it. Try to find an avascular plane. If you can't find, use a 25 gauge needle. Go in once and come out.
Yeah. Okay. Okay. Great. So I think we've pretty much answered all the questions. What I'm going to do is we can just wrap up. I'm going to just put some links here if anybody's interested in seeing the video, whatever of this, or even from yesterday's session. I think there are people who could not attend, which was more on the basics of the anatomy, the basic preparations, indications, etc. We'll be having these uploaded on these channels this week. And next week, there is an ongoing Eus masterclass for those who are not aware. Dr. Dheer is you're the president of SGI now. So SGI has organized this wonderful masterclass series going through the more sort of advanced things. There is the next week on Saturday, there is the EUS guided pancreatic interventions, and I've been honored to be part of it, and I'll be presenting on technical tips on LAMPs. And there are several fantastic talks on PD intervention, necrosectomy, and EUS guided collections with drainage of collections with plastic stents as well by all our renowned national faculty. So look forward to all of you who are interested in this being there. And I think we can sort of close the session. We are in time. It's 12:29. So thank you all for being here, and a lot of thank you again to Olympus and Boston Scientific for supporting us and getting this done successfully. So thank you, Dr. Dheer, for sparing your Sunday morning. Hopefully, you can get going with your day's work, and it's your day off. Okay, so and hopefully that's Srijesh. You want to say something?
Yeah.
Or?
No, sir. Thank you so much, and it's been a wonderful 2-day session from your end. And thank you, Dr. Dheer, for being part of it. And we look forward for many such events in future. Thank you, everyone, all the participants, attendees who joined us.
Something.
Thank you.
Okay, thank you. Okay.